So I will go ahead and get started. Good afternoon, everyone. Welcome to the AOGME webinar series. We are pleased to have you here this afternoon and join us on our GME development series entitled Outcomes Data from Community-Based and Rural Residency Programs. My name is Katina Rue, and I'm the chair of the AOGME Education Committee, and I'm going to help facilitate this webinar. Before we get started, I'd like to review a few housekeeping notes. This webinar is being recorded, and the recording will be posted on the AOGME webpage within about 7 calendar days. And all of the participants are in listen-only mode. If you experience any difficulties, please reach out to us in the chat and we will assist you. And if you have any questions during the webinar, please use the Q&A feature or put them in the chat, and we will hopefully have some time to answer questions at the end. I'm also excited to announce that the osteopathic physicians who are here today can earn up to 1.0 hour of AOA Category 1A CME for attending the webinar. In order to obtain your CME, just complete the post-webinar evaluation and email us at aogme@acom.org so we can get you that attestation form. So now I'm going to go ahead and introduce our speakers today. First, we've got Emily Hawes, PharmD. She's a professor in the University of North Carolina School of Medicine, Department of Family Medicine, and a research fellow at the UNC Cecil G. Sheps Center for Health Services Research. She serves as the Deputy Director of the HRSA-funded Rural Residency and Teaching Health Center Technical Assistance Centers. She practices as a clinical pharmacist practitioner, providing collaborative drug therapy management in a primary care clinic in rural Western North Carolina. Dr. Hawes' research focuses on team-based primary care, health workforce policy, rural health, and graduate medical education program development in rural and underserved areas. We also have Dr. Candice Chen. She's the Associate Administrator for the Bureau of Health Workforce at HRSA, which aims to improve health by strengthening the workforce and connecting providers to communities in need. BHW manages over 70 programs with a $1.9 million budget, supporting a diverse, culturally competent workforce across the education to service continuum. Dr. Chen previously led BHW's Division of Medicine and Dentistry from 2014 to 2018 and was a faculty member at George Washington University, focusing on primary care, underserved communities, and workforce policy. A board-certified pediatrician, she earned her MD from Baylor, completed training at Children's National Hospital, and holds an MPH from GWU, continuing to practice in Southeast Washington, D.C. Thank you for joining us today and sharing your expertise. And with that, I'll turn it over to you, Dr. Chen.
Thank you. Thank you very much. And I'm really excited to be here with you all today. I think what we're talking about is community-based training programs. And I'm going to, I think, provide you a little bit of information about some of the HRSA investments and opportunities in community-based training, and then hand it over to Dr. Emily Hawes to give you the real story about all of it, I think, and hopefully we'll get a chance to do some question and answer. I think I'm going to do a little bit of sharing here. Let me see. Okay, so hopefully you can see my PowerPoint, and if you can't, I trust somebody will tell me that that is the case. And so again, oopsie. Okay, so just to really quickly start off with, I am the Associate Administrator of the Bureau of Health Workforce, currently inside of the Health Resources and Services Administration, HRSA, although you may have seen that we are going through a reorganization and will soon be consolidated into the Administration for a Healthy America. But for now, and I suspect even in the future, what our primary mission is to really improve health for underserved populations. And under the Bureau of Health Workforce, the way we do that is by strengthening the workforce. And strengthening the workforce means that we are thinking about who we recruit, the educational pathways, how we train, where we train, and ultimately our programs that help to incentivize service in the communities of highest need. And well, I kind of ran through this just now. Our strategies for success, just to reiterate, is again thinking about who we recruit. We know that when we recruit from the communities of need, that whether that's rural, whether that's underserved communities, that those individuals, as they move their way through healthcare, education, and training, are ultimately the most likely to go home to practice. That we know that the both where we train and how we train matters for rural and underserved communities. And one of the things I always do like to point out is it's not just increasing the likelihood that somebody will choose to practice in the communities that they train in, but when we train in community health centers, in rural communities, and we train for the care that we ultimately want people to be able to provide, the product that you get will be better. And when people are well trained, and then ultimately, hopefully, well supported to be able to deliver care in rural and underserved communities, I believe retention will be better as well. And so we train to enhance, and we also train to enhance the training and the content of the training for the quality of care. And finally, I'll talk a little bit about our loan repayment programs, our scholarship and loan repayment programs, and the idea of providing incentives. Honestly, that counter, I think, some of the incentives not to unfortunately practice in rural and underserved settings. And so just really quickly, I think one of the programs that for this audience you tend to be the most interested in, and is in fact the program that Emily and her team are currently supporting through the Technical Assistance Center, is the Teaching Health Center Graduate Medical Education Program. And if you don't know about the Teaching Health Center program, one of the things I have to recognize right now is that ACOM has a very positive and strong history with the Teaching Health Center GME program. The prior, and now I'm going to get his title wrong, but we'll say CEO of ACOM, president and CEO maybe of ACOM, Steve Shannon, I think was really instrumental in the inclusion of the Teaching Health Center, the passage of the legislation that established the Teaching Health Center Graduate Medical Education Program. In fact, in about 2010, right before 2010, I remember at one point, as particularly the osteopathic community was really getting behind this idea of the Teaching Health Center GME bill and legislation. I think that he flew, I think, home from Maine, and happened to run into the senator, a really important senator at the time for what was then the Affordable Care Act, and managed to stop and give her a very quick briefing on the Teaching Health Center legislative proposal. So yeah, very, very important history. And then ACOM has always been a very strong proponent, I think, as well as an implementer, I would say, of the Teaching Health Center GME program. And if you don't know the Teaching Health Center GME program, I think it's really special because it does something a little bit different than Medicare GME, and in most states, the way Medicaid GME is set up to support residency training programs. It specifically requires that the sponsoring institution for the program has to be either the community-based ambulatory site or a consortium where the community-based site is a primary partner. So it kind of flips the linkage to hospitals on its head and says, we want residency programs that are focused in community-based setting, and then you have to be a primary care specialty as well, both medicine and dentistry. And so a really, I think, important program for expanding and supporting residency training in primary care and in community-based settings. And here's just some quick stats about the teaching health centers. We collect so much information from all of our grantees, but I think the teaching health centers has really stood as a model for both, I think, submitting data that really tells the story of the teaching health centers, but then also individuals in the community doing research that just demonstrates the value of this program. I think one of the important things is for teaching health centers, you have to either expand your existing program or be a new program. So every physician, primary care physician and dentist that's produced is an additional physician or dentist that potentially wouldn't exist without the teaching health center program. And from 2011, when the program first started, we graduated supported the training of almost 3,000 new primary care providers. About 85% of recent graduates are working in medically underserved communities. And today we are supporting just over 1,200 residents, about 20% of them from rural backgrounds, in 82 programs across 27 states. I have a couple more numbers just showing that we really do train, or the teaching health centers really do train in underserved communities and primary care settings and rural communities. And I think one of the important things about residency programs is that residents and the faculty that oversee residents are delivering care. And so a lot of patient care is being delivered by the teaching health center programs. Here are some more outcomes just showing that really the teaching health center graduate outcomes are achieving the intent of the program. 18% in rural areas compared to just under 12% for other programs. A high percentage of people ultimately choose to practice within 5 miles of their residency, high percentages in medically underserved communities, and specifically in community health centers. And this is just a quick look at how the teaching health center program is contributing to actually closing the shortages in the different healthcare providers. The percentages are small, but every one of these providers, I think, when you can take care of, maybe on the lower end, we'll say 1,000 patients. On the upper end, debatable what it should be, but 2,500 patients. Every one of these graduates makes a difference in their community. And I think that's really important to keep in mind. Outside of the teaching health center program, other programs that are run out of HRSA, the Rural Residency Planning and Development Program, which I know that we have people on the call who have utilized this Rural Residency Planning and Development Program. Emily and her team also support the development of these residency programs. This is actually run out of the Federal Office of Rural Health Policy, so not out of my particular bureau, but it was done in partnership between the Bureau of Health Workforce, the Federal Office of Rural Health Policy, in recognition for the fact that residency programs don't just appear magically. It takes investment, and particularly if we're talking about rural communities, if we're talking about underserved communities for the teaching health center program, it's important to make those investments and support communities to be able to start new residency programs. And then we have to think about things like the sustainability and ongoing funding of those programs. And then another one of the things I did want to talk about is beyond the GME programs, whether it's a planning and development grant or whether it's a GME payment program, we run a number of grant programs, and I think that these grant programs can also be really, really important for communities. They're used in a lot of different ways to sometimes expand programs, sometimes enhance programs. We do have a couple of more grant programs that are focused on residency training, like our preventive medicine residency program. We have an addiction medicine fellowship program. And then we have programs that are aimed at supporting training inside of community-based settings, particularly like our primary care training enhancement. We have advanced nursing education that's done things like support nurse practitioner residency program. And I know that you all are probably a little bit more focused on the physician pathway, but I think one of the things that we find is when you start to partner with community-based organizations, that your community-based organizations, your community health centers have much more expansive needs. And if we're going to support physicians And as a physician myself, one of the things I always think about is as a physician, if my nurses, if I'm not fully and well staffed, if my nurses are we're having retention issues with our nurses, having a lot of turnover with our medical assistants, ultimately that affects the entire team, that affects well-being and affects delivery of care. And so really the need to think about the entire team. And so some of these programs really provide opportunities in those other places. Um, and I think that there are, what we interestingly find, I think, is that sometimes as organizations are coming in and maybe they start with a teaching health center program, as they get settled in the teaching health center program, and realize the value of a grow your own approach, as well as the fact that they can do it. What we often find is that they then turn towards the other professions, and turn towards training their own in some of these other areas as well. And the last thing I think I have today is it's always just a good idea. We're doing we have the grant programs to support the education and training. We have our GME programs that explicitly support the GME payments. But then once people are out, we want to be able to support them in service in rural and underserved communities and kind of counteract maybe the cost of education, the debt that they have. Scholarship does that in one way. The majority of our programs and our funds actually go out through loan repayment in exchange. We have National Health Service Corps, we have Nurse Corps, we have something called the Substance Use Disorder Treatment and Recovery Loan Repayment Program, and a couple of others that, particularly for you all as you are thinking about supporting your students in your residence, knowing about these programs and the availability of these programs, I think is really, really important. And I think that's what I have. Actually, I lied. We have a couple more resources. I think that you'll get all of these. I think one of the things that is worth highlighting is that we do have something called the Health Workforce Connector. So for people who are looking for opportunities where they might be eligible, and work opportunities where they might be eligible for, say, National Health Service Corps, Nurse Corps, loan repayment. We have something called the Health Workforce Connector. And in that Health Workforce Connector, one of the things that we're trying to do is also feature the places that have teaching health center programs. So to help people find those programs. And then truly the rest of the slides are just highlighting some of the resources and where you can find them on our website. And now I am truly done, Emily, and I am handing it to you. Stop share.
Wonderful. Let me. Oh my, I'm having. Okay, can you see my screen?
Yes.
Okay, wonderful. So I think it's very fitting to go after Dr. Chen because all that I'm about to share is because of HRSA programs. And so it's really exciting, and also want to just acknowledge the important role that HRSA has played in workforce development. I'm also joined today by a key team member on our Technical Assistance Center, Lori Rodfeld. She's the Director of GME Development, has done state-based work and is doing state-based work in Wisconsin, and also is part of our National Technical Assistance Centers. So I want to just thank you all for being here today, and especially want to thank you for hosting me at Educating Leaders. I absolutely loved getting to be get to know comms more and just appreciate osteopathic medicine and the role that you all have. So today I'm going to be sharing some of what I shared at Educating Leaders, entitled Rural and Community-Based Graduate Medical Education. We're going to look at expansion and get encouraged about how things have grown and shaped over the years, the impact and what we're finding in some of these technical assistant data sets, and then opportunities where we can improve because barriers certainly still persist. Please note that we are federally funded, and I've listed our disclosures here. And again, our views today, what we share, is not necessarily representing the official HRSA or HHS perspective. We have a wonderful team at UNC, and want to acknowledge that several of the things that I'm sharing today are projects that we've worked on over the years. Before I dive into our research, I want to share a little bit of my frame. I'm a practicing primary care-based pharmacist, as Dr. Rue shared, educator and consumer board member at an FQHC in the beautiful mountains of Boone, North Carolina. And the healthcare facilities and community that I'm in are impacted by inadequate workforce. And I see this day in, day out, or every week as I'm seeing patients. Our FQHC in particular is really struggling to hire psychiatrists and dentists. So we see this maldistribution nationwide. And one of the contributing factors is that we have a maldistribution of training by setting and geography. And what is exciting to see based on the research that's been published is that training makes a difference. It's a powerful lever to increase the care for rural and community-based and underserved populations, which is why you're here today. So let's look first at how rural and community-based GME has expanded. And I want to acknowledge, I looked at the participants in the Zoom room and just want to say thank you, because many of you have contributed to this expansion on the ground in your communities, in your rural and FQHC communities. So thank you. One of the questions we get a lot, especially on Capitol Hill, is can these rural health facilities and FQHCs actually support GME? And the answer is yes. They can develop their own programs and support GME development. They need startup funding and technical assistance. So these two HRSA programs that I have on the slide are supporting new program development. Since 2019, HRSA's Rural Residency Planning and Development program provides startup funding and technical assistance, has created 61 new accredited residencies. These are all numbers that actually were just updated today. Since 2021, the Bureau of Health Workforce, through the Teaching Health Center Planning and Development program, has provided seed funding and technical assistance to start new medical and dental residencies, and has established 42 new accredited programs. Now, the plan for them, because FQHCs are not able to access Medicare GME financing, the plan is for many of them to receive Teaching Health Center graduate medical education grants from HRSA, which are needed to fund residency operations in community-based settings. Collectively, these federal programs are supporting the development of 177 programs across 45 states and 10 specialties, 103 accredited programs with over 1,200 resident positions. So thank you all. I see many grantees in the room. Thank you for your hard work in contributing to that. I'm going to ask Alinta and team to drop a recent publication that happened this week that came out in Health Affairs showing the growth of rural and underserved training, and also the contribution of federal and osteopathic accreditation in contributing to this growth. As you can see, looking at this figure, looking at rural-based programs where greater than 50% training is occurring in those rural locations, you can see teal represents programs that were previously AOA accredited. Now, I want to acknowledge that this research effort was done in collaboration with AOA as well as the ACGME. Red includes those programs that received RRPD funding, and yellow represents the THC PD and or THC GME funded grants. So you see that about 28% of the 2023 rural programs were previously AOA accredited. You all should celebrate. And a little over 21% were RRPD grant recipients. With respect to programs where greater than 50% training is occurring in health centers, according to ACGME data, you can see that almost 23% of the 2023 health center-based programs were previously AOA accredited, and a little over 28% were Teaching Health Center grant recipients. We were limited in the number of exhibits that we could include, but I told Alinta, and I want to share this with you all too, that we do have this broken down by those programs that have sites, health center sites, as well as rural sites. And so I'm happy to share that with you after the webinar. Green on these slides represents rural physician training. The darker the green, the more rural training time. And the circles represent the number of programs. As you can see when comparing 2008 to the bottom right of 2023 data, training has grown in rural areas. In fact, there are over 400 programs with rural sites. So it was about 120 back in 2008, and now over 400 sites. So it just shows this capacity of the interest of rural health facilities to engage in training. The findings are similar for training in FQHCs, with blue representing FQHC training. More than 300 programs have FQHC sites based on current data. As shown on the red line, programs with greater than 50% of training time in rural areas have more than doubled, whereas those with at least half of training time occurring in FQHCs has increased from 1 to 2.6%, seen on that purplish blue line. So the expansion of these rotation sites is extremely encouraging to me as these health facilities are preparing for learners. And what we've seen kind of nationally is that starting with rotation can be a catalyst for developing a program. This is really probably hard to see, but you can see on the top of this table that in 2008, actually, rural program growth has been greatest in family medicine, internal medicine, and psychiatry, whereas FQHC-based program growth has been highest in family medicine. I'm going to pause for a second because there's a lot to digest in this, and I think you can see there's been a significant growth. So 6.1% of rural programs had rural sites back in 2008, where we have 14.3% of residencies having rural sites in 2023. 3.5% had FQHC sites back in 2008, and now we have 11.17 in 2023. So it's a significant amount of growth, and a lot of this has been related to HRSA investment. The South has the highest percentage of rural programs, 8.35%, while the West does for the FQHC-based programs, which aligns with trends in population growth. So although GME is largely concentrated in urban academic medical centers, it's clear that GME has expanded in places and settings of need, and this is critical given that the impact is profound. We know that, as Dr. Chen mentioned, that how and where you train impacts how and where you practice. These programs are recruiting and retaining graduates to underserved settings. Published research shows that 1 in 4 THC GME graduates are practicing in FQHCs, 65% in primary care. I know most of this is about medical, but I just want to highlight this, that dentists who complete community-based postgraduate training are more likely to accept Medicaid patients. Rural trained family physicians are at least twice as likely, 2 to 5 times as likely based on some of the research, to practice in rural settings. And although our sample size is small and results are preliminary, our RRPD graduate locations are aligning with this existing evidence, as you can see on the slide. GME is increasing access to care and fostering team-based models of care, which Dr. Chen mentioned. New expanding services like resurrecting obstetric services. It's also bringing behavioral health services and staff. One of the programs we supported hired 3 LCSWs for 1 facility at the onset of their residency. It's ensuring not only that treatment for opioid use disorder are being offered in health facilities, but that trainees are equipped to offer these services following graduation. New school-based services, mobile farm worker initiatives, street medicine, and care for those impacted by incarceration are being established. This is something that we are submitting and hope to get in press to hopefully help, again, clearly show the value and ROI for GME impacting communities. We also know from published research, I think that Dr. Chen was engaged in, that graduates of these types of programs are more likely to continue the broad scope of practice and team-based care following training. So they end up practicing different because of the way that they're trained. I want to acknowledge Dr. Beck in the room, as well as Dr. Natasha Bray for their work. As you can see, a picture of their program, their COM on the slide. So oftentimes people forget that residents are actually seeing patients and improving access to care. The Osteopathic Medical Education Consortium of Oklahoma, which received RRPD funding to start their program and has ongoing THC, GME, HRSA grants to cover operations, is training family med residents in rural tribal facilities in Tahlequah. They're actually training beyond family medicine, but I want to use a specific example that Dr. Beck shared with me, that within 6 months of starting the residency, wait times for assignments to a PCP reduced from 9 months to 3 months. Of the 17 graduates, 9 have stayed and remained employed with Cherokee Nation Health Services. 1 graduate is providing family medicine obstetrical services on their campus, and another is providing wound care services that were not previously available to patients outside of the care of the surgeon. And I will include a link of a wonderful blog that featured Dr. Beck, and some of this information was taken from an ACGME blog. GME is catalyzing the growth of other interprofessional primary care programs. The RRPD and Teaching Health Center programs are teaching us that training leads to more training. And I'm sure as each of you kind of reflect on your situations, you've probably seen that play out in your own communities and health facilities. El Rio Health Center is serving in urban underserved Tucson, Arizona, and some of their journey of interprofessional teaching is shown on this slide in chronological order. And I want to thank Dr. Spegman for letting me borrow this slide from him. They started with medical school rotations through AT Still Soma, a dental residency, a family medicine residency, a pharmacy residency, a pediatric residency, another family medicine residency, an NP residency, and now a newly developed accredited psychiatry residency. You see that once these rural health facilities and FQHCs, along with their clinicians, shore up their academic infrastructure and adopt this educational mission to align with the clinical mission, which is challenging but important in starting these programs, their GME and their IPE seem to grow and grow. I want to thank Dr. Freyer and Dr. Lombardi at UNC Sheps for collaborating on this research. In our effort to quantify how often training co-location is happening, we analyzed the percentage of PCP training programs co-located with primary care training sites. I know this is a busy slide, so the distribution of co-location of PCP training programs is evidenced by the spike. So the higher the spike, the higher the number of programs. The color is the proportion of those sites that are co-located, so with darker purple representing those higher percentages. Although almost half of the counties with primary physician programs have co-located pharmacy residency sites, we see lots of opportunities where primary care sites are not co-located, as you can see just spanning the country. We just looked at kind of the difference in different covariates. As you can imagine, there's a lower rate of co-location in rural areas, and we are actually expanding this to looking at dental training sites and want to look at FQHCs. My hypothesis is that we'll see higher co-location in FQHCs, but stay tuned for more kind of analysis. Even with all this progress, and I hope you're encouraged today because I know many of you are doing this work, barriers still persist, and there's significant opportunity to increase and sustain rural and community-based GME. THC GME funding for residency operations is critical. And increased as well as sustained funding is needed. As you likely know, community health centers are not able to directly access adequate Medicare GME financing, and most of the Medicare financing focuses on hospital-based training in urban areas. HRSA is making a difference in trying to address this inequity by funding medical, dental, NP, PA, behavioral health, nursing, and other training in a variety of community-based underserved settings. HRSA's THC GME grants are providing funding for training embedded in community-based organizations like FQHCs. But unlike Medicare, THC GME funding is based on periodic congressional appropriations, not an entitlement. Thus, the program has faced several fiscal cliffs where funding is set to expire unless Congress extends the program. There is currently a fiscal cliff set for September 2025. And what we've seen, and also I want to acknowledge on the slide too, a costing study that showed a rate of $210,000 for training residents compared to the current $160,000 PRA. This financial uncertainty, and we're seeing this time and time again, jeopardizes the growth and sustainability of this impactful program. And I could talk a long time about that, but I'll shift to the next slide. This map shows the distribution and number of training sites for the Teaching Health Center program. The Planning and Development program provided startup funding to 92 community health centers and has the capacity to expand the reach of the Teaching Health Center program to 13 new states, as you can see in yellow, that previously did not have teaching health centers. These programs are projected to create over 900 new resident positions, which would nearly double the existing footprint of the Teaching Health Center program. But THCGME funding, these HRSA grants for residency operations, are needed to fully unlock this potential expansion and ensure that the close to $50 million invested by Congress to start these programs are not wasted. Programs like Tampa Health Center Pediatrics received accreditation and then pulled their rank list just before the match. And there are several others that were ready and held back because of the lack of funding. Programs like DePaul in New Orleans, Louisiana, and El Rio Psychiatry pulled their rank list last year, but then this year they decided to not delay recruitment another year. So they successfully matched residents, but they need THCGME dollars to sustain their commenced programs. As you heard, several of you actually in your questions submitted to us before this webinar mentioned questions about Medicare and barriers with Medicare. Traditional Medicare caps have and continue to limit growth and sustainability. There have been and will continue to be positive impacts that we're seeing with the Consolidated Appropriations Act of 2021. Removing the separate accreditation requirement to be eligible for CMS Rural Track Program funding has helped programs like the University of Tennessee at Chattanooga Family Medicine Program expand training into a new rural community in Bledsoe County. Attaining separate accreditation can be costly and time intensive. So we anticipate continuing to see this more efficiently grow the rural GME footprint. Campbell University College of Osteopathic Medicine also established a rural track program after the enactment of CAA 21. And each month we're seeing more and more programs begin rural track programs because of the removing of separate accreditation. Barriers still persist though. Section 131 allows for resetting of artificially low per resident amount or caps that have been set by rural rotators or other inadvertent situations. But unfortunately, this is set to expire this December 2025. We are recommending an extension or even removing this deadline. The other barrier that we frequently hear is that the ramp up to 5 years to build that cap is just not enough time for a rural program to realize their full training capacity. So I put a picture of Marshfield, an exceptional rural program in Wisconsin that realized their full training potential after the 5-year period. They want to expand their rural IM program by 6 positions. They secured additional payment slots after their 3rd attempt in applying for Section 126 slots. However, they only received partial positions, so they can't really, even though they have this capacity, they don't have the financing to be able to do it. So we need to look at policy solutions that help those that are currently training residents that have inadequate funding, as well as pathways to bolster new program development. And that's true for both teaching health centers and hospitals. Hospital type impacts sustainability, and there are nuances around a variety of hospital types. Several of you submitted questions about different hospital types, so I was going to mostly focus on sole community Medicare dependent, but I want to deviate a little bit. IHS facilities are not able to directly access adequate Medicare GME dollars. So really right now, the mechanism that is supporting a lot of these tribal-based programs, which are certainly not enough, is the THC GME grants. Critical access hospitals can serve as non-provider sites in partnership with urban hospitals and receive new Medicare GME dollars. We are seeing lots of critical access hospitals actually engage in GME because of this. And so there is a proposed policy reform for IHS hospitals to benefit from or to potentially be able to utilize the non-provider site pathway. I do want to share about sole community and Medicare dependent hospitals, which I think is really important because it counts for about a fourth of rural hospitals. And they often have these ideal characteristics for teaching with respect to volume and bed size and mix of cases. Although only 15% of them, according to cost report data, are participating in GME at this time, 40% of the RRPD grant recipients have Medicare dependent and sole community hospital sites. So we anticipate seeing the number participating in GME increasing. As some of you may know, these hospitals only receive DGME and do not receive the full IME, which is typically about 2/3, so a big chunk of that Medicare funding. We conducted an analysis to get to the bottom of these implications and looked at Medicare cost report for the past 10 years and found that these hospital types experience a $70,000 per resident deficit compared to IPPS hospitals, as you can see on this figure. So we are recommending a payment modification to offset these opportunity costs, like an add-on payment. Geographic classification limits funding eligibility. Looking at the figure of San Bernardino County, which is classified as a metropolitan county, but you can see that most of the county is far from LA and is considered FORP rural, which is in the green. The metropolitan status means that new residencies anywhere within that county are currently ineligible for CMS funding as a rural track program. Forbes' definition of rural is based on analyzing rurality in smaller geographic areas, so in census tracts. And interestingly, there are about 400 more hospitals in FORP rural areas compared to non-metropolitan counties. So just changing that rural track eligibility based on more precise geographic classification could open up even more opportunity for rural training and for you all as you're partnering with hospitals. We're also seeing that states are providing funding for technical assistance, startup, and sustainability. And we're seeing this braiding together of state, private, and federal efforts to leverage and strengthen rural and community-based settings. On the slides are just many of the grant recipients that are benefiting from this linkage, including a psychiatry program in Moultrie, Georgia, the University of Arizona Phoenix Com, and a program receives funding in New Mexico through a state plan amendment that actually enabled an additional $100K for each primary care or psychiatry resident trained. We have a study underway and look forward to sharing more information about how states are kind of leveraging these mechanisms. And then I want to close by sharing hopeful news that micro policy issues are being translated into broader macro policy solutions. Sometimes it can be hard to think that your story can make a difference, but we have seen stories make a difference. So this left picture represents St. Luke's Miners Memorial Hospital, one of the first RRPD grant recipients in rural Coaldale, Pennsylvania, that started a residency in a 74-bed Medicare dependent hospital. They realized when they were, preparing and planning for their residency that they just did not have adequate funding based on their pro formas. And they encountered this friction and then they shared it broadly. They shared their story with a local newspaper that actually featured it, and then it was shared with policymakers, both state and federal, HRSA, and then our Technical Assistance Center. So then we were asked to evaluate it, and I shared the results with you earlier, and we were able to then inform Senate Finance, GOP Dr. Caucus, Ways and Means, several different subcommittees. And now there is we can drop the link, actually it may be on these slides that we'll disseminate afterwards. There is a solution, a proposed policy change that would help mitigate this inequity. And I really want to leave you with the importance of sharing both your successes as well as your frictions, because those inform research and then collectively can be incorporated into broader reaching solutions that we hope will address the maldistribution of training in these settings. So thank you so much for letting me share. And I do want to allow time for Lori, myself, and Dr. Chen to answer any questions that you have.
Thank you so much. Please feel free to put any questions you may have in the chat. We've got about 13 more minutes to answer questions. And if I don't see anything in the chat or in the Q&A, I will go back to our questions that were submitted previously, if I can find that link.
And
look
while
through
you're
those.
doing that, Dr. Rue, I may see if Lori, do you have anything you want to add based on what I've shared?
I would say, it's just been such an honor to work with the different grant recipients. And just, the highlight is really like the exit surveys. Also, the highlight is being an advisor and working with programs kind of day in and day out, and hearing, their successes, their challenges, and how they've overcome different challenges. It's just been an honor to work with all of them. And again, it's so neat to see so many in this Zoom room who have been either involved in our THC PD work or RRPD work or the THC GME work. So we touch a lot of you in the osteopathic community. And again, I think it's just so impactful when you look at the data, you look at the impact of the osteopathic community to the growth of these programs. It's really just amazing.
The stories are powerful, right? It looks like we have a question. How do you attract residents into the rural programs? And I would love Lori to share her perspective on this. But I do want to highlight there was a recent article that just was published based on researchers out of the University of Washington that looked at kind of the influence of surgery training. And one of the interesting things, and I think I need to read it in more detail, but it looked like rural mission had a higher influence on kind of future rural practice if these surgeons went into rural practice. And as they were describing the mission, it really focused on the attraction of certain residents, aligning missions and making sure that that fit is right in the recruitment. And I think that's what we hear over and over again is aligning on that mission and making sure that you're very clear on that mission, which so many of you are doing in your comms.
Yeah, and I just want to build on what Emily shared. I think that the mission is so important, and really finding those aligned GME partners and UME partners. I know that, a lot of the programs that I work with, I really encourage them to build strong relationships with their medical school partners, and often comms are much easier to work with than, say, large academic medical centers or medical schools. So again, developing those strong partnerships, knowing what you're looking for in a student. If you have that right student go to the right program, you're going to have a stronger likelihood of a match. I actually previously worked at a AOA rural track program that later transitioned into ACGME, and actually 2/3 of our residents were former students. So I think that if you can get the right students to your program, they're going to want to stay. They're going to want to train there. And then I also want to do a quick plug for our Rural GME webinar next week. We're actually going to be talking about NRMP exceptions, and I think that this is such a wonderful opportunity in my state of Wisconsin. We have 4 of them where we actually directly take students from a medical school and put them into a residency program. I see Dr. Moran on, and I worked with him to set up an NRMP exception. So great to see you on the call. And we set up a wonderful Rural Scholar program. We're hoping we can set up more of those. And my dream would be that we could even expand that into health centers. But again, that's something that we've got to tackle one thing at a time. But it's been, I think, a really great pathway to get those rurally interested students directly into a program. And what's really neat is when they start as a medical student, training there, then they start residency with a leg up ahead of everyone else. They're kind of like a chief intern, as they get started in their program.
Excuse me, a couple of questions that were submitted beforehand that spoke to rural surgery workforce. Is there, do you have additional data to share other than Dr. Hawes, what you just mentioned, or any way to recruit rural surgeons and getting them to stick in our rural communities?
So I'm gonna get the link to provide to you, but I do want to highlight that I think the biggest barrier there's a lot of, it seems like there's a lot of interest among students to go into rural surgery. And I know we're seeing this as we're kind of learning about the student interests. And but as of right now, there's very few that can meet the CMS rural track eligibility to have greater than 50% training in non-metropolitan communities. We are deep into an analysis on looking at the sweet spot for hospitals that could meet Medicare eligibility and also those that maybe have state funding for lower percent training time. We don't know as much about the impact of a smaller percentage of training time onto where they practice. And so that is an area that we just secured data and are hoping to kind of analyze that more broadly and share that information with you. Lori, I know you've had rural surgery experience that you may want to elaborate on.
Yeah, in my state, we actually have 3 rural surgery programs, and we have a 100% fill rate. And whenever I go talk with medical students, and we go talk to medical students throughout the region, I would say a quarter to a third are interested in rural surgery. There's just not programs for them to go into. So I commend those who are interested in creating these programs. We know that we need rural surgeons. We have deserts where there are no surgeons, and a patient shouldn't have to travel over an hour to see a surgeon or get emergency care. But that's the case in a lot of rural America. But looking at these programs, like Emily said, there's such a mix in how they're structured and created. We actually have 1 truly rural surgery program. The other 2 offer rural rotations. But again, I'll just kind of highlight our UW rural surgery program. They just expanded to 2 positions this current year, but they got, I think, 400 applications from US MDs and DOs for those 2 spots. So again, there's a huge appetite for this type of training. We just need to create more programs, but they're only doing about 18 months of rural training, but 75% of their graduates are practicing rural. So again, the training time matters, but even an 18-month rural surgery experience can lead to 75% actual rural practice. So again, I think it's something we need to grow and develop. But I also want to highlight that many surgery programs have a rural mission, and that's just as significant. If there is a strong rural mission, they can be very successful in placing their grads into rural communities as well.
We received a question about how do you track retention? And I want to acknowledge that the THC GME program, we're able to spout off all of these outcomes and be able to do subsequent research on the scope of practice following these programs because of the way that HRSA collects performance report data. So there's accountability with the teaching health center program. And I think it's a model that we are seeing used in other states as they are providing state funding for training. They're saying, hey, if we're providing this funding, you have to report back to us. And so I think that's a good model. I will say it is hard to track graduate. We use AMA, MPES, state licensure data is what has been best for us in North Carolina, but it is hard. And I highly recommend keeping those relationships with your graduates and trying to get accurate practice data, because the outcomes and reporting and metrics matter. Dr. Chen, do you have anything else to add?
I super appreciate you saying that, particularly because I think it was about 10 years ago that I implemented the collection of NPI numbers for all of the teaching health centers. But I have to say that all the teaching health centers out there, we were a little bit nervous when we did it, but every one of the teaching health centers fully understood what we were doing and why we were doing it. And internally, we have been able to take those NPI numbers and start to do the work to track them. And I have to say that I think that as we move forward, what we're hoping is that the data gets better and better, and we don't have to maybe go to things like the AMA master file or the NPI and the NPPS, the NPI data set, but instead that we might start to go to claims data. And through claims data that we might start to be able to say things like, this is where this person is, and this is how much Medicaid service they provided. So we continue to push in that direction, in part also to try to make it easier for our grantees, because each one of you, that would be a lot to ask of each one of you. We're not there yet, but we're working that way.
There's time for one final question, and then there's a comment in the chat that I would like to acknowledge. Oh, and then there's another comment in the chat.
I think that last one is for you, Dr. Chen.
Yeah, I think that last one is probably for me. And so just to give you all a little bit of a update, I would say, on the funding for the Teaching Health Center program. It's the Teaching Health Center program for this fiscal year 2025, which if you don't follow fiscal years, I wouldn't expect you to. Fiscal years run from October 1st to September 30th. And the funding for this year is effectively flat from what it was in FY24 at about $175 million. And what happened is, and I'm assuming that this residency program in the fall of 2024, we did open a competition to potentially award new teaching health center programs, recognizing that teaching health centers have to know whether, or potential teaching health centers have to know whether or not they're going to be funded in order to start residence in academic year 25-26. We opened it with the caveat that unless the program saw new funding, we wouldn't be able to make new awards. And if we're flat funded from FY24 and we're flat funded to FY25, that means we did not get new funding, and that means we are not making new awards for start in academic year 25-26. We know that there are, as Emily shared, that there are a lot of planning and development grantees out there. Some of the people who came in for the competition, we know took residence for academic year 25-26. And if any of you are out there and haven't been on some of the calls that we've done with those grantees, please feel free to reach out. What we're trying to understand is how many programs took residents, how many residents there are in the field. We cannot create the money to be able to fund them, but if asked, we want to be able to provide that information to all of our key stakeholders, with the possibility that if the program saw more funding, that we might be able to do that. It will very, very much depend on what Congress does. And just to be frank, Congress could act before September 30th, but I think that we're kind of looking at that September 30th date as the most likely time that they might act. if you don't follow the teaching health centers, we oftentimes are in the mandatory funding with National Health Service Corps and Community Health Center program. And the Community Health Center program actually would, quote, fall off a funding cliff a little earlier than some of our other programs. And so oftentimes generates the need of this act. So again, we're kind of watching that September 30th date. But you should always feel free if you're confused, if you're uncertain, this is to just reach out to us.
And your story can make a difference. Like what you are doing, just looking at the Zoom room, these stories are so impactful. So please share them. And I posted Dr. Beck's wonderful blog.
Well, it is 2 o'clock, everyone. I'd like to extend a big, huge thank you to Dr. Chen, Dr. Hawes, and Ms. Rodefield for being here. And for all of our participants here on Zoom, don't forget to click the link to get your AOA CME and complete that form. The webinar recording will be out there within a week, and we will see you at our next webinar. Thanks for being here.
Thank you.